Now the next lecture is by Dr. K.C. Misra, sir. He is head of the department, Sikandrabad, Yashoda Hospital, Somajigoda unit. Sorry, his top will be on fungal biomarkers. Time for consensus.
Finally, I'm here. At the outset, I should thank Dr. Bhavani, Dr. Deepak, and the whole critic team to giving me this opportunity to be here and share the stage. Since maybe last 7 years, I'm thinking that at some point of time I'll be here and talking on something. Uh, thank you, thank you very much. And second most important thing is at the maybe around 5 o'clock now, I see around 70 people sitting, and not all are speakers. People are there who are listening carefully. That itself is a big deal. So let us come to the topic. 15 minutes is a very less time to talk about biomarker. There are new things also. Most of the biomarkers are not available in India. So the things what we know, what we do day in and out, that those things I will discuss in detail, like galactomannan and 1,3-beta-D-glucan. Rest of the things are, let's see, those biomarkers are maybe theoretical interest, or maybe in future once those things are available, we need to know. So there are few slides on that, but I can't discuss in detail because of time constraints. So going to the biomarker before, some epidemiology, if you see, uh, Candida is one of the most common invasive fungal infection. It is the fourth most common like Candidemia when it comes to US. After that it comes Aspergillus. If you see the mortality, Candidiasis can go up to 60 to 75% mortality, whereas Aspergillosis can reach up to 95% when it comes to pulmonary aspergillosis and all. Things are not much different in India. There is a study from AIMS itself. The overall Candidemia comes to around 8 per thousand admitted patients. And interestingly, in medical ICU, the invasive candidiasis or fungal infection can go up to 15%. In there, they have seen that most of the cases are aspergillus, not candida. And the most common people where they find this aspergillus is autoimmune disease patient and chronic liver disease patient. In ICU, the percentage of people developing candidemia goes up to 15%, whereas in the ward it is around 5%. So there is a significant difference because we are talking about critical care, we are talking about ICU. Invasive fungal infection is very, very common. Incidence of invasive candidiasis in medical ICU, the incidence is around 7%, whereas in India, if you see the mean when the patient can develop candidiasis compared to the Western countries is very early, within 8 days, whereas in Western countries can go up to 15 days. And most of our people are comparatively young and less serious. And Candida tropicalis is more common than Candida albicans and all, where we have difficulties in treating those cases if we delay in diagnosing these cases. There is one more study. Let's see, when the city is showing like it most probably it is a fungal infection. In those cases of febrile neutropenia, where we believe the city findings correlate with a fungal infection also, 30% of people only we can think of fungal infection. In 19% of them, we can go with a biopsy. Out of that, 44% people have fungal infection, and most of them are aspergillus, few of them are mucormycosis. One more interesting study, if you see in epidemiology, there is like in Chandigarh, they have seen the fungal spore in the normal air of an hospital. When it comes to ICU, interestingly, the spore count is less, whereas in the ward, the spore count goes up to 122. There are many reasons. Let's see the tropical environment, the amount of antibiotics used, and all those things comes to into picture. So fungal is there in air, and in India, the fungal infection rate is higher. Even the younger age group people and non-critical patients are getting fungal infection. Apart from, we know that neutropenic patients, immunocompromised patients, they will have fungal infections. The conventional technique when it comes to diagnosing a fungal infection are microscopy. Most of the time we do KOS, sometimes gram stain and all. Other than that, the gold standard is still culture and histopathology. From there, we'll do again culture. The efficacy, if you see the culture and all, even if the culture is gold standard, the efficacy for different fungal infection is very, very low, and the time taken to get a pulsar cause positivity goes up to 2 weeks. So Cryptococcus is highest, around 95% time it is positive. Candidiasis is 50 to 60% of time. Aspergillus even less. Histoplasma, again the culture growth is higher. But we should mind in that, like the culture positivity when it comes to a fungal infection may take up to 2 weeks time. So there the picture or the importance of biomarker comes. Say biomarker is nothing but a product which comes from the fungus or yeast, some cell body or from their cell wall and all those things, which is not the conventional way of diagnosing a fungal infection, allowing early and anticipated diagnosis of invasive fungal infection. So after looking at all those epidemiology, one thing is clear that if we diagnose or we can anticipate a fungal infection, we can treat them better, by which the mortality will come down. The main reason is the high mortality, low sensitivity of the available techniques, and the gold standard culture takes a very long time. There are many fungal biomarkers has been postulated for different ways. Let's say to diagnose a case of fungal infection, to prognosticate a case of fungal infection, even to see the like the treatment, how the patient is responding to the treatment. There are different biomarkers. There is an overlap in all the biomarkers also. We'll go, like as I've told, the common biomarkers we'll discuss maybe in little detail. So coming to the galactomannan, one of the most important. So galactomannan is a carbohydrate which is there in Aspergillus cell wall, and it is whenever there is some angio invasion, it will be there in the blood, it will be there in the bronchoalveolar like bowel samples, and other body fluids like urine, CSF, everywhere we can have galactomannan. FDA is approved only for serum and bowel. Other things FDA is not approved, and there is no standardizing that. One of the, like we do galactomannan test by enzyme immunoassay, and the report whatever is coming, we call it to be optical density index. The manufacturer itself has given negative to be less than 0.5, positive to be more than 0.5, but there is a meta-analysis. You see, when the value is higher, the specificity will increase, whereas sensitivity will come down. So we have to see some middle ground where the sensitivity will be high and specificity will be high. So when they have seen the cutoff value of 1, both sensitivity and specificity is much higher. So they have taken the sample to be 1. If it is less than 1, we say to be negative, more than 1, it is to be positive. So beta-lactam antibodies, where we see galactomannan to be falsely positive. I am running through the slides because the 15 minutes is very less. So when, in which conditions we see false positivity when it comes to galactomannan? One of the important thing what we see is somebody is on beta-lactam antibiotics like piperacillin, tavactam or amoxiclav. They say even if you have discontinued the antibiotic for the next 5 days also galactomannan can be positive. But there is a recent study in AIMS where they have seen the recent batch of the recent molecules what we are using, they don't interfere much with the galactomannan. Even plasma light can cause false positive galactomannan. IVIG therapy, even for 2 to 3 weeks galactomannan can be positive. Somebody is having severe mucosite, graft versus host disease, all these patients can have false positive galactomannan. Enteral nutrition, multiple myeloma, or there are other antifungals like histoplasma, blastomycosis and all, where you can have positive galactomannan. These are the false positivity when it comes to galactomannan. Coming to the sensitivity, if you see the immunocompromised people like hematological malignancy or people undergoing bone marrow transplant or people having solid organ transplant patients, most of the time the sensitivity and specificity is reasonably good, except solid organ transplant patient, the sensitivity is very low. It is comes to around 20 to 30% only. So to diagnose or anticipate, let's say, aspergillus in a solid organ transplant patient might be very, very low. So patient on anti-mold therapy, let's say somebody is on prophylaxis, already on prophylaxis, in those cases the sensitivity and specificity goes down drastically. Solid organ transplant, I was told the sensitivity is only 22%. Non-neutropenic patients, because the chances of having angio invasion is less. So these people, non-neutropenic patient on immunosuppression, here also the chances of having a high galactomannan is very less. Then other conditions like where we don't see angio invasion or invasive aspergillosis like aspergilloma, chronic pulmonary aspergillosis, patient with cystic fibrosis or chronic granulomatous diseases, in these conditions like your galactomannan results might be normal. CSF galactomannan also has been tried, and it is validated that if it is high, we can say that there might be some meningitis because of aspergillosis. Clinical utility is very important. It can be used in patients with neutropenia or maybe immunocompromised patient. If the galactomannan is high, it can show like patients having higher galactomannan after 13 to 14 days, they will show clinical symptoms of fungal infections. Hematological malignancy patient, they have seen 6 days before diagnosis, you can see a galactomannan to be positive. Bulk galactomannan before having radiological signs in the CT or X-ray, your galactomannan can be positive up to a week to 4 weeks before that. So it's very, very important so that at least we can get to know that this patient is most probably in next few days or in week or two can develop a aspergillus infections. We can see the response to the therapy also. If the galactomannan is very high, mortality is high. If galactomannan is coming down drastically after the treatment, they are going to be respond well and they tend to do well. Preemptive therapy in febrile neutropenia also has been studied. Galactomannan utilize, if galactomannan is high, you can start off antifungal. By that, unnecessary antifungal treatment will be less. Preemptive and prophylactic treatment can be decreased. Whom to test? Suspected cases of invasive fungal infections, mostly aspergillosis in neutropenic hematological malignancy patient mind. One thing we should think of, these people should not be on anti-mold treatment. Anti-mold treatment is there if those people are already on antifungal. If you do and galactomannan, it can be low. Beta-3, 1,3 beta-D-glucan, one of the important, second most important we can say when it comes to biomarkers. Again, it is a component of cell wall and it is a pan-fungal antigen. See, most of the fungus, like let it be Candida, let it be Aspergillus, even your PJP, most of the fungus they have 1,3 beta-D-glucan, except maybe Cryptococcus and one or two more. Any invasive fungal infection, 1,3 beta-D-glucan will be high. Negative is less than 60, positive is more than 80. Sensitivity and specificity is around 80%, which is good when it comes to 1,3 beta-D-glucan. Invasive candidiasis sensitivity and specificity is around 80, whereas invasive aspergillosis sensitivity is bit low, specificity around 77%. Clinical utility, again, beta-D-glucan can give us a time, like before the patient having clinical signs and symptoms of fungal infections, we can get at least a positive report 2 to 7 days before. An invasive aspergillosis 4 to 15 days before signs and symptoms, we can get a positive report. And interestingly, let's see the patients where we want to start antifungal treatment, thinking that there is a possibility of invasive candidiasis or maybe aspergillosis, and you do a beta-D-glucan. If it is negative, the negative predictive value is so high, these people may not require any antifungal. That is again important. Beta-D-glucan negative predictive value is very high. Preemptive therapy is beta-D-glucan is high, we can think of starting. If it is low, we can stop. What they have told in the patients who are prone to develop fungal infection, you do twice weekly beta-D-glucan, which can identify at least 87% of invasive candidiasis before they have the signs and symptoms. You can treat them early. Deep-seated fungal infections like candidiasis also will be positive if you do a beta-D-glucan, whereas most of the time cultures come out to be negative. Even pneumocystis jirovecii or pneumocystis pneumonia, the sensitivity and specificity of beta-D-glucan is very high. It goes beyond 90%. So if you suspect and let's see an HIV or non-HIV patient, pneumocystis pneumonia, if it is high, most probably it is not only colonizer, it is infecting. You should start treating those cases. There are studies on that, both in HIV and non-HIV, which correlates well. Better if it is beta-D-glucan is positive, you should start treating those cases. CSF also they have seen, which is if you believe that candidiasis or something, a patient having nosocomial meningitis, you are suspecting it to be a fungus, beta-D-glucan has some role. Ball beta-D-glucan, if it is positive, but the levels has to be very high to think in terms of a fungal infection in those cases. The limitations are it is not a truly pan-fungal biomarker. Cryptococcus and mucormycosis, blastomycosis and all usually doesn't produce any beta-D-glucan. Even if somebody is on hemodialysis, beta-D-glucan may be falsely positive. Even different form of bacteremia can have false positive beta-D-glucan. A lot of antibiotics, including the common antibiotics what we use in and out in our ICUs, if those are there, if somebody is on those antibiotics, beta-D-glucan can be falsely positive. IVIG is like in galactomannan, beta-D-glucan also IVIG can cause false positive report. If somebody is on receive different transfusion, let it be whole blood, PRBC, FFP, all those things can cause false positive results. Even surgical gauze, somebody's burn patients or somebody underwent abdominal surgery, also beta-D-glucan can be a false positive report. As I've told, beta-D-glucan has more negative predictive value than positive predictive value. Candida, mannan, antimannan. Mannan is one of the Candida albicans cell body things, and antimannan is the antibody against that mannan antibody. There are studies where they have seen when we do both mannan and antimannan together, where we are suspecting candidiasis, then sensitivity and specificity goes beyond 80%. But I don't think it is available in India. The utility is, again, we can diagnose candidiasis early before they have all the signs and symptoms. Limitations different, like Candida parapsilosis Guillermondi doesn't produce much of mannan, so we don't see anti-mannan in those cases. Cryptococcal antigen, again, this is GXM is what the cellular polysaccharide there in Cryptococcus can be done in both enzyme and enzyme immunoassay or lattice agglutination test. Both the test has significant sensitivity and specificity. Sensitivity and specificity go beyond 90% when it comes to cryptococcal antigen. And if you see, we know that cryptococcus usually we see in HIV patients. If somebody is HIV with meningitis, if the cryptococcal antigen is positive, then probably this patient with surety we can start cryptococcal antigen. In the meantime, there are two things. If somebody has had cryptococcal infection before, the antigenemia can be there for a period of time. In those cases, antibody production or antigen testing may not have much of utility. Histoplasma urinary antigen, again, is the specificity and sensitivity is very high. Almost the specificity 99%, sensitivity is around 80%, can be used in histoplasma cases by doing just a urinary antigen test. Few of the other fungus also, there may be a false positive test. T2 candida is a newer kid in the block, which they have seen that different types of candida also we can diagnose. Out of 5 more different type of species of candida we can diagnose, where the amplified DNA target will be detected by T2 magnetic resonance. The candidemia and deep-seated candida both can be accurately diagnosed up to 80 to 90% of the time. Maybe it is upcoming thing. In future we'll be doing more and more candida PCR. The infection and colonizer will be a difficult thing, but PCR is sensitive and specificity both goes beyond 90%. Candida PCR and Aspergillus lateral flow device, again one of the newer things which has shown promising results when it comes to Aspergillus with a very high detection rate. Take home points, serum galactomannan has excellent diagnostic utility in neutropenic patients who are not on any anti-mold prophylaxis. Serum galactomannan measured bi-weekly can be used as a preemptive therapy in neutropenic patients and we can monitor treatment with that. Bal-galactomannan has excellent diagnostic utility, especially in non-neutropenic patients. Beta-D-glucan has high false positive results, whereas it is an excellent negative predictive value. Serum cryptococcal antigen is good in diagnosing and treating patients if they don't have cryptococcal infection before. Thank you very much. If there is any questions, I can take.
Dr. Casey, thank you for that lucid talk. My question is, in the era of multiplex PCRs, do you think there is a role for these biomarkers at all? Especially because these are questions where we have a high suspicion. Before you're sending galactomannan, you're suspecting there's a fungal infection. Before you send a 1,3 beta 2 galactan. So when you have a multiplex PCRs for fungal, pan-fungal panels and whatnot, in this era, if you get a nice tissue sample, you get to do a BAL, you can directly send for a multiplex PCR rather than doing a galactomannan, which will give you false positives. There are so many questions in that situation. So what would you say the role of biomarkers is?
Hey, now I will answer you in this way. Actually, this is no direct answer for your question, but still, let's see. PCR can detect, let it be a dead or alive virus. That is one.
Fungus.
Whenever,
Fungus.
well, we are talking about fungus, sorry. So fungus. Second thing is, see, the problem with the PCR is the sensitivity is very high, specificity may not be there. It can detect 5 fungus at a time. You will never know which is the true fungus or true infecting fungus in that case. The validity of PCR for most of the fungus at this point of time is not there, whatever I have seen the literature. Fourth thing is, let's see, when we are doing a test, let it be culture or other things also in a sterile site, sensitivity and specificity of PCR will be higher. Wherever in a non-sterile site, let's say you are thinking that there is an infection in the lung and you are doing a PCR, there is a high probability that you will end up in false positive reports instead of true positive or specific reports will not be there. So PCR has its own issues. That's the reason PCR I have told in the last, not in the first.
No, still what I'm saying is the relatively, how do you use it? If you have a pneumonia, let's say, and you're suspecting fungus.
Thank you. And thank you, Dr. Pawan, for your question actually.
May I call all the speaker on the stage, including Dr. Ankit also. Any question from audience?
May I have some comments? So I'm Dr. Kilnani. I'm incidentally here. So something called incidentaloma. That is I was in Hyderabad. I contacted Venkat and he said, come. That is so. As I'm just unsolicited comment I'm giving that looking at 3-4 presentations that I heard, I think future of critical care is very bright. They are these young lads, all of them. Pawan, you are also young. Don't think I'm not commenting on you. The amazing presentation. They will can be compared with any international presentation, any forum. I have been to all the conferences, almost the pulmonary critical conference. I go every year for last 35 years. It's such an evidence-based and experience-based. Wherever the limitations are so nicely brought out by everybody. So I will ask one question each to everybody. Just and you could see I was taking pictures of your slides, and I may use it sometime. They were so good. So Ankit, first question to you is, how will you compare isavuconazole with posaconazole? I think the topic could have been, because uh, what I could make out from your amazing presentation that there's no doubt that amphotericin remains the drug of choice. There's no question. But posaconazole, we have been using it for almost a decade now, and it has been the spectrum of posaconazole is increasing. Isavuconazole is relatively come later. From your presentation, I was thinking that comparison should be between posaconazole and isavuconazole. So what do you think?
So I think between posaconazole and isavuconazole, there are certain pros and cons with each drug.
In context of mucor.
Yes, in context of mucor, the CNS penetration with isavuconazole is generally better. So if you're treating a CNS
Yeah,
infection, that is
that
probably
point.
when isavu should be preferred. But for and also when QTC is an issue, cardiac patient, when drug therapeutic monitoring is an issue, then those are the situations where isavuconazole might be a better choice. But for every other purpose, for the management of mucor, including cost effectiveness, posaconazole becomes the drug of choice. And even in the outcomes we had seen between POSA and
Yeah.
isavuconazole, they had a slightly better outcome with POSA compared to.
So I just wanted to give, although your topic was that, I want to give a message. Nobody should leave this hall with the idea that
Correct.
isavuconazole is better than posaconazole. Dr. Misra, I have a comment about your. I'm sorry, Venkat. I'm a pulmonologist. I do bronchoscopies all the time, and I'm critical care physician also. And we also know that fungal infections of the lung are increasing. We are seeing more and more in immunocompetent patients. And you talked about fungal ball. So it's so difficult to make out whether there's an invasion also. So you need. So when I do ball, so what do you do ball? You go to a particular segment and you push fluid. You may push 100 ml fluid and bring out only 5 ml. Sometime 30 ml will come, sometime 20 ml. What I'm trying to come out is that in ball the return is variable. What you push and what you bring out. The disease may be in the right lower lobe anterior segment and majority may come from the posterior segment or even from the other lung for that matter. And it is a quantitative test. So based on the studies, putting a hard cutoff of 1, in my experience has been totally not. Sometime it is 3, 4, and I don't find any evidence of fungal infection. So I don't think one should go by treating only based on the one thing I use in my practice, which is not evidence based. I also concomitantly do serum galactomannan. If both are positive, then I'm little more sure, but that is extremely rare. So I want your comment on that.
Sir, very difficult question, sir.
That's why I'm asking you. You have studied the subject so well.
Now, one thing actually what has been mentioned, sir, if serum is coming positive, it has to be invasive. There has to be some angio invasion. Without that, it should not come into the serum.
Sure.
And if, let's see,
But also the serum is, even in pulmonary, serum is very occasionally high, And majority of patients who are in the ICU or otherwise will be on beta-lactam antibiotics.
actually beta-lactam antibodies, actually there is a study from AIMS, even the recent up-to-date also what has been mentioned is, even the newer batch of or whatever the piperacillin tazobactam in amoxiclav, they don't interfere much with galactomannan what has been told. But I'm not sure actually, at least the recent guidelines or recent thing they're suggesting if somebody is on beta-lactam also should not cause much of interference with the galactomannan. I think as you told, no sir, if the dilution is a factor, we are not sure. We are pushing 50 ml, we are taking 5 ml, we are pushing 100 ml, we are taking 5 ml. The dilution might be different. In
And
that case,
you may be in a different segment.
segment. So in that cases, I think there is a significant objective variability might be there. We cannot make sure that it has to be more than one or less than one. It is very difficult. But as you told, I think both maybe BAL and serum can give us an idea. There are some data on serum versus urine also. The more than 0.26.
Sorry if I could interrupt you in the interest of time. Is there, I spoke to Dr. Aruna Loke Chattopadhyay on this because he is the benchmark.
No doubt, sir.
And he also said, he agreed with me, number one. Number two, he said it depends upon the what method you are doing for assessing the galactomannan. That also matters. So if you have any idea, then tell us.
No, sir, not much, sir.
Okay, all right. So, yes. Go to the mic, please.
Sir, in a non-neutropenic host, there is no role for doing a serum galactomannan because the sensitivity of galactomannan for identifying pulmonary aspergillosis in a non-neutropenic host is only 20%. Because it is basically we look for the galactomannan present in the cell wall. In a neutropenic host, the neutrophils eats away. So that's the reason we 80% of the time we don't see. So the diagnosis of pulmonary aspergillosis in a non-neutropenic host should be based on the host and the radiological presentation plus BAL galactomannan positive, and that also we say only probable. Ultimately, the final thing is the biopsy. So there is no, I mean, we shouldn't try to do both and try to give a comparison and try to make a diagnosis.
No, but you can't be, no, sorry, I'm interrupting.
Sir.
You can't be very dogmatic about it. I'll tell you why. When I was studying long time back, mucor and diabetics were, if somebody was not a diabetic, mucor cannot be there. But today you are seeing mucormycosis, and similarly, sometime you see aspergillus first and immunodeficiency later. So one should not go with a hard. This is my personal opinion.
Yes.
That galactomannan is not used for patients who are non-neutropenic. Certainly, it is more useful in a neutropenic patient and also in retroviral patients.
In the blood, sir, I meant to say in the blood.
As a blood.
In the blood, sir. In BAL, yes, sir. Any host you can use. When it comes to the blood, non-neutropenic host, the sensitivity is
The
very
point
poor.
well taken. So, interest of time, Dr. Pawan, आपके लिए question. In the end, you said that this multiplex PCR or biotechnology based can also be used for de-escalation. I'm sorry, I don't agree with you. Convince me how you go on the mic and.
Majority of the times in the de-escalation in the sense if there is a confirmation, I'm not saying it as a negative
Okay.
verdict. If you confirm some diagnosis, some sort of, let's say strep pneumonia has come and the patient is on meropenem, it doesn't need meropenem for strep pneumonia. If you get a culture with stenotrophomonas, let's say a PCR is positive for
So
stenotrophomonas, that kind of thing.
So it
So-
cannot be. So that is not true de-escalation.
But by the time we empirically start something and we send off, in 24 hours you're getting the report.
You know my
And if it-
interest in antibiotics, so So if you say de-escalation, my mind goes totally on a different.
So it's just that it corroborates with the diagnosis for an empirical starting. of an antibiotic, you can probably de-escalate from the empirical to targeted therapy. So in a sense, it might not be, it is choosing antibiotic stewardship rather than going to the appropriate antibiotic rather than throwing everything, especially in immunocompromised patients. We see that.
So my last fourth speaker. No, I can't ask you anything because I have no knowledge about that subject. Thank you very much.
Thank you, everybody. So I'd like to call upon Dr. Srujan for felicitate Dr. Pawan, sir.
Thank you very much and sorry for encroaching you.
Dr. Charan. Uh, I'd like to request Dr. Khilani, sir, to felicitate Dr. Misra, sir. Now, Dr. Ankit. To felicitate our chairpersons, I would like to call Dr. Chandana madam on stage. Sir, please wait. So